All right. So now in this particular discussion, we'll look at the management of patient who comes with bends. So before we look at that, we are going to first of all describe what bends are. Then finally, we'll look at how to manage such a particular patient. So what are bends? So bends, saying these are tissue injuries. They are a type of tissue injuries that patients acquire when they come in contact with flames. This is dry heat, hot liquids, or moist heat, if you like, gases, surfaces that are hot, sometimes it's chemicals or electricity. Needless to say, this causes some form of damage to the skin. This is a superficial most part of our body. It's a protective covering. So once we come in contact with something, that will be the first part of the body to be bent. So you see that depending on the layers of the skin involved, we can classify and differentiate different types of bends. Sometimes the skin is broken. Sometimes the skin remains intact, but still the person has bends. So let's look at some of the causes. So first of all is flames from fire sources. This time we are now dealing with, gas stove, firewood, burning buildings, houses, and so on and so forth. Steamed water, this is boiling water. Spills, these are common in babies. The baby may wander off from the caregivers. The next thing, you find they are spilling water, and that can cause burns. Chemicals, mainly we're talking about corrosive substances such as acids and alkali. Then we have lightning, which is rare but can cause electric burns, lightning burn. Then we also have electricity. This is common, especially where there are faulty wiring, power disruption that causes short circuits and electric shocks. Then we have friction, body surface, especially the skin, being dragged against a hard surface or against a hot, surface. So these are the causes of burns. Classification of burns mainly is by two criteria. You can classify burns looking at what caused that particular burn. Is it a burn resulting from, dry heat? Is it a burn resulting from chemicals? We can also classify burns depending on the extent and depth of damage to the body that it has done. So the first criteria is based on the cause. So burns caused by, heat, usually call them thermal burns. So sources of heat, especially dry flames, hot plates, so on and so forth. Electrical burns, of course, the cause of that burn is an electrical source, an electrical fault. Chemical burns, of course, we're talking about corrosive agents, like I was saying, acids and alkali, then cold, thermal burns. Mainly we're talking about frostbite and the likes, where individuals are exposed to extremely low temperatures and causes damage to the skin. Then we have inhalation burns, usually coming from smoking burns or burning buildings. Individuals who are trapped and then inhale smoke. That smoke comes with heat and damages internal organ, most importantly, the lungs. So those are the types of burns depending on the source or cause of that injury. Classification based on extent and depth of body surface area, we're looking at which layers of the skin are affected. So skin has the following layers. We have the the epidermis, sorry. That's the epidermis there, composed of epithelial tissue or epithelial cells. Then we go into the dermis, which is connective tissue, connective tissue proper. You find dense and loose connective tissue there. Then the third layer is a subcutaneous layer, or the hypodermis, also composed of connective tissue, but a particular special type of connective tissue called alveolar tissue, which is mainly composed of fat. Now, in addition to that, you see that in this skin specimen, there are various other structures found there. Most importantly, blood vessels, skin appendages like hair follicles. You have sebaceous glands there. Then you have different types of nerve collections. You have Pacinian, you have Meissner's, corpuscles. These are different type of nerves specialized to detect pressure, touch, pain, and so on. So those are skin appendages. And when the person is exposed to bends, some of these structures, or most of them, will be bent depending on the size and extent of the bends that they have. Hair follicles will be bent, some of the nerves will be bent, or some of them will be exposed because the dermis and epidermis are gone, and that will cause a lot of pain. Now, where the nerve endings are also damaged, then pain sensation drops, and such a bend may be painless. So the deeper the bends, the more painless they become. So based on that, we're now going to classify bends depending on the depth. So we have superficial bends. These are bends that affect only the epidermis. So these are not so extensive. Okay, so you may see a blister forming because of separation of those epithelial cells and fluid accumulating in those areas where there is separation, causing a blister, quite painful. Okay, and once a blister ruptures, you see plasma and exudate escaping from that blister, causing serious pain now because the nerve endings are exposed. Number two, under depth, we're looking at partial thickness, or what we call second degree bends. Now, second degree bends involve two layers of the skin, that is epidermis and the dermis, with or without breakage of the epidermis. Now, because of this bend, you find again there will be separation between the epidermis and the dermis, causing a blister. Because of the two layers involved, you see that healing will take some bit of more time. Remember, we are concerned most importantly with the fibroblasts. These are cells that synthesize collagen and repair connective tissue, so it requires a lot of time to repair that damage that has occurred. Example given there, we see a blister in that baby's hand. That's because of fluid accumulating between the dermis and epidermis. Very painful. Once it's exposed, or once the blister ruptures, as air is passing through, you see that there's a lot of pain that is being stimulated. Next, we have full thickness, or what we can call third degree bends. Now, third degree bends involve all the three layers of the skin: epidermis, dermis, and the hypodermis. So that's why it's called full thickness. Those three layers are involved. In addition to that, the skin appendages are also affected. Structures like hair follicles, sebaceous glands, sweat glands, nerve endings are also damaged. So because of that damage to the nerve endings, you find that pain is less as compared to second degree and superficial bends. Okay, and regeneration takes quite a longer period of time because of the extent of the damage. The body needs a lot of time, especially fibroblasts, which are responsible for synthesis of new connective tissue in the area of the damage. You can see the diagram there, this person having some bends. Then we have complicated bends. Now, complicated bends is a combination of full thickness plus involvement of other deeper structures. Most importantly, you're talking about muscles, their tendons, and their fascia. To some extent, may go as deep as the skeletal system, bending all the way to the bone. Acids can do that. Corrosive acids, hydrochloric acid, such kind of acids can damage all the way to the bone, tissue. So all the skin appendages are lost. Nails, hair, whatever, sweat glands, sebaceous glands, gone. And because of that, there's risk of infection, risk of loss of, thermoregulation because the skin is involved in temperature control. So that person loses heat quite faster and may actually develop hypothermia, especially in younger children. So that's fourth, or what you can call complicated burns. All the layers involved plus other deeper structures in there. Now, because of burn, especially to the muscles, now muscles exist in compartments. The best example I can give, if you check your arm, you have biceps in front of your arm and triceps at the back there. Now, those muscles are surrounded by a layer of connective tissue, more like a wrapping. That is a compartment. So you have a compartment of biceps, compartment of triceps. Because of injury caused by burns and disturbance to the fascia that surrounds the muscle, causing those compartments, you find that sometimes pressure builds up because of the inflammatory process taking place there. Fascia surround groups of muscles. So fluid is accumulating, but it doesn't have where to go. So pressure builds up, nerves are compressed, blood vessels are compressed. Now, blood vessels are compressed, tissues begin to die. Nerve will start producing pain. So such a problem is called compartment syndrome. So you see, such may be a complication in various types of burns. Now, when it comes to this type of burns, most importantly, treatment, this patient requires grafting, all right, because healing on their own is difficult. Most of the underlying connective tissue is gone, and wound healing is dependent on the presence of connective tissue because that's where we get the fibroblast and the components needed to form and repair new connective tissue, what we call granulation. So depending on the extent of the damage and the site of the damage, an amputation could be the more reasonable approach. So those are the types or classification of burns under depth and extent of damage. 4, superficial, second degree, third degree, and complicated burns. You can see this is complicated burns, severe burns there. And this changing color of the skin, what you call eschar. This is sloughing off of skin. You can see those areas. This skin will fall off so that the underlying tissue can regenerate. Now, as it builds at this stage, you find that it may cause, various complications, especially over joints, the elbow, on the wrist, because as the skin is healing, there's that contraction that occurs as a result of contraction of the myofibroblasts found in the skin, and that can actually cause a contracture, a permanent flexion of the joint there. So usually find incisions made through this new tissue that is forming to prevent such complications. So this is a summary, of classification of burns depending on the depth. So you have the depth, level of injury involved, characteristics that you see, and prognosis from such type of a burn. So not spend so much time there. We can look at the pathophysiology. What happens when a person is burned? So there are about 4 stages through which the body will undergo. So we have neurogenic shock. The body is aware now. The nervous system is sensitized. And in response to that, you see that the sympathetic nervous system may cause various signs in this person. Irritability, some loss of, plasma volume because of blood vessels dilating and so on. Fluid shift, because of the shock that occurs, blood vessels dilate, the inflammatory process that is occurring again, blood vessels dilate, and then fluid are lost to the interstitial spaces away from the blood vessels. Then we have sloughing off. Now, sloughing off is falling off the burnt tissue because of the regeneration of the new tissue. So the burnt tissue falls off. so that new tissue is formed. Then finally there is repair. So there's new tissue that is occurring or forming from the deeper underlying connective tissue. So we start with the first stage, which is a neurogenic stage. So this stage mainly is because of stimulation of the nerve endings found in the skin and that pain that is produced when exposed to pain. So that severe pain stimulates pain receptors. Pain stimulation is called nociception because those receptors are called nociceptors. Now, because of that, you may see various sympathetic reaction. Okay, the body is sympathizing. So adrenaline is secreted, blood vessels dilate, heart rate increases. In addition to that, this person is frightened because of the experience that they've seen. Some may become hysterical, others they may just be enter into stupor, no response whatsoever, pupil dilated, heart rate very high, breathing rate also increases. So this is a nervous system responding to that initial contact with the burning agent, which can be electricity, dry frames, acids, and so on. Okay. So now, the next stage we're looking at is the fluid shift. Now, what fluid shift mainly is because of increased vascular permeability. Okay, so vascular permeability, capillaries dilate, especially in the areas of the injury itself. If it's in the arm, you see that there will be edema and swelling in that arm because of the capillary dilatation. In some instances, you find that other areas of the body also, or they can just be generalized vasodilatation causing now generalized edema. So we see this in the first hour upon injury, and there will be extensive leakage of fluid from the vascular space into the interstitial, spaces. And what you see now is swelling. That swelling also may increase the pain sensation. Okay. Okay. We're talking about systemic effects of fluid shift. What happens if that fluid is shifting from the blood vessels into the tissue? So you see hemato concentration. So the hematocrit goes up because plasma is lost. So because of that, blood flow becomes slow. And that can predispose to condition known as disseminated intravascular coagulopathy, where red blood cells begin to clog and may cause blockage into medium and smaller blood vessels. Next is reduced cardiac output. The volume of blood ejected by the heart drops because the fluid has shifted from the blood vessels into the tissues. Most patients may develop anemia, especially those with severe burns because of hemolysis of red blood cells. So those are some of the effects. Okay, now we reach the sloughing off stage. What happens? So there's eschar formation. That dead layer of the skin, because of the injury resulting from burns, is now detaching because healing is taking place underneath there. So it's pushed off. It's no longer functional. There are no blood vessels taking nutrients and gases to that, damaged, layer of the skin. So it falls off. Process known as liquefaction. And this can now leave an open wound. Okay, so you see them usually turns whitish, grayish. That is an eschar that forms because of the dead, cells or dead tissues. Okay, now because of that, there will be now exposure of the external environment to the external environment. So you see this person losing temperature quickly and also becoming susceptible to infection, which is usually detected by change of color, presence of pus or pus formation, or simply fever. Usually fever seen much later during the day and at night. There are various types of microorganisms that cause now infection when that dead tissue falls off, what we call eschar. Finally, the last stage or process then is repair. there's now repair of the burnt tissue. So mainly it's by regeneration. So new tissue or connective tissue is formed called the granulation tissue. So you see new blood vessels growing into the area of the wound, bringing along with it, immune cells, nutrients, gases, and so on. Because of that, the dead, part or the dead tissue falls off. So you see that that tissue becomes more red because of extensive blood vessels growing there, like you can see in these areas. That is new tissue growing, granular tissue. Then here we have dead tissue or Eshka, if you like, which is sloughing off. So those are the stages of the pathophysiology of burns. What happens? The body is sensitized, neurogenic, shock, then there's fluid shift, slough formation, and repair. Okay. So we can now look at the clinical manifestations of burns. First of all, there will be severe pain or mild pain. Severe pain mainly associated with superficial and partial thickness burns. Then full thickness and complicated burns, usually they have mild pain, and they usually feel pain when you apply pressure on the wound. Otherwise, they are more painless, if I can use that word. Blisters. Again, depending on the type of burn. Is it involving all the layers or the two layers or just a superficial layer? That's when you see blisters. Superficial, and when the dermis is involved, also you see blisters. Then there's reduced fluid volume. So because of the shift of blood plasma from blood vessels into the tissues, the fluid volume drops, and this can lead to shock. What is causing the shift of fluid is because of increased permeability in the capillaries. Because of that, urine output drops. So patient may experience oliguria, diminished urine output, which can later on complicate into renal failure. If patient develops anuria, there will be now an insult or assault to the, kidneys, especially the nephron, because most of the cardiac output, about 60% or so, blood from the heart goes to the kidneys, and that can drop significantly in this instance when the patient has burns. Cold and clammy extremities, these are signs of shock and dehydration now. You see, patient is losing fluid. So blood flow to the peripheries and extremities is shunted. Little blood is going there, so extremities become cold and clammy. What do you do? Now looking at the management, this patient comes with, burns. First of all, we must prepare the environment to receive such a patient. All right, so we need various equipments readily available. Number one is catheter tray, IV solutions, sterile gloves to make sure that we maintain aseptic techniques. Bed cradle, of course, to lift the linen off the sides of burns so that there's no, stickiness or attachment of the linen to the areas of the wound. Because of the exudate that is found on the wounds and the clotting factors found in plasma, you find that will be that stickiness that may cause extensive pain when you're trying to separate them, the linen from the wound. Clean linen, of course, this is to prevent infection, tracheostomy set, especially for patients who have been exposed to burns of the upper respiratory tract, face, head, neck, burns in those areas. There might be an indication for tracheostomy. Then suction machine, oxygen administration equipment, either by cylinder or oxygen machine. Blood withdrawal syringes and needles, cross-match bottles in an event that you need to transfuse this patient, depending again on the extent of burns that they've received. Then laboratory forms and a nasogastric tube set. Feeding may be affected depending on the site of burns. Quickly assess the patient. So what we want to do is to resuscitate the patient. So quickly do head-to-toe assessment Assess respiratory function, cardiovascular function. See that the patient is not in shock. Okay, if patient is in shock, quickly resuscitate. So we follow principles of airway, breathing, circulation, and drug administration. So A, B, C, D. Airway. Make sure the airway is patent. So we must be mindful of the position that the client is in, especially those that are unconscious. Make sure that the airway is not blocked. So neck must be extended and tilted to one side. Breathing, you monitor the rising and falling of the chest, the breathing pattern, and also oxygen saturation. Then pulse, heart rate must be monitored. That's for cardiovascular function. You want to make sure that the pulse is rhythmical and with a good force. A thready and intermittent pulse may indicate shock. Then administer any drugs that are necessary at this particular point in time, especially pain management. And if there's need to stimulate the heart, adrenaline can be administered. And also administer any prescribed IV fluids. Okay. Quickly get your history, age, name, sex. You want to know also the type of pain that the patient was exposed to. So do your quick and thorough history. Nature, source, and duration of exposure to the burning agent, associated injuries, and state of the health of the patient prior to the burns. Okay, then assess the face. What you're concerned with here is obstruction. Is there any obstruction? So nose, mouth, make sure that there are no burns. Sometimes this could be, debris from the burning material in which the patient was. That can actually occlude the airway. So you must make sure that the nostrils are clear. Sometimes it could be the hair that is bent in the nose, called vibrissae, that can cause obstruction. Extremities, you want to see both extremities, if at all there were any burns. Next, inspect the genitalia. Okay, we see that most of the burns associated with the genitalia lead to infection. Then if you can take height as well, quickly do that, because that will be used, especially in trying to see if the patient is responding to your fluids or whether the edema is subsiding. Next, calculate the total burn surface area. Of course, we use the rule of 9. And here what I have is a rule of 9 for adults. Of course, the total body surface area is 100. So you want to know out of 100, what's the burn surface area? All right. So we see that according to the rule of 9, you can use a diagram here. So the head is given 9%. The anterior trunk also is 9%. 9 for the thorax, 9 for the abdomen and pelvis there. So anterior trunk, 18. Posterior trunk, 18. Upper limb. So one upper limb, both front and back, is equals to 9. So 9 for one upper limb, 9 for the other upper limb. So together, both upper limbs account for 18%. Then if you go down to the lower limb, the anterior part of the lower limb, the whole lot of it is 9%. Equally, the posterior part of the lower limb is 9%. So one lower limb accounts for 18. If you add both of them, 18 plus 18, that is coming to somewhere 30, 36. Yeah. So that is for the lower limbs. Then the remaining, because if you add the rest, if you add 9, 18 front, 18 back, 18 for the both hands, and 36 for the two lower limbs, that comes to 99. The remaining 1% goes for the genitalia. All right. So total will be 100 for the entire body surface area. Now, body surface area is important when you want to calculate fluids now. Okay, now in an event that the bent surface are scattered, we use a palm. So the palm accounts for 1% of your body surface area. So you can use that to approximate and come up with the total bent surface area, not body surface area, but total bent surface area. That is important in calculation of fluid that you're going to administer in the first 24 hours post bends. So there are various investigations that we are going to do. Of course, you must do history and physical examination. Of course, blood sample can be collected if you're interested, especially with, the blood, urea, and nitrogen. Now, these are additional investigations that we are doing. Most importantly, physical exam. You don't need a test to confirm that the patient has been bent. You don't need an oximeter reading to know that this patient was exposed to a bend. Those are just additional information, even a full blood count. You don't need it at this stage. You may need it just to now for further management, but for you to know that this patient has bends, you observe, you see, and see which areas of the body were bent. History now will give you prior to the bends, how was the status of the patient and what's the nature of the bend itself. Urinalysis can be done. Of course, you want to detect if there are any, urinary system abnormalities or complications setting in. So we're concerned mainly with the volume of urine. We know that, for adults, in an hour, we're supposed to have, somewhere 50 mils of urine. Yeah. So full blood count, urinalysis, BUN, erythrocyte sedimentation rate, those are just additional tests that can be done. Okay. What is important is make sure that this patient is resuscitated first through ABC and initiate fluid therapy. Of course, looking at the extent of the bent surface area, you may need to keep this patient warm. You're preventing infection, preventing shock, you're preventing hypothermia. So those are some of the aims of managing a patient under bends. Airway is important, followed by fluid resuscitation, prevent shock, pain management, prevention of infection, and prevention of hypothermia. Now, when it comes to calculation of fluids, the first 24 hours of life is critical. If I can put it, first 3 days, because that's when most of these vital organs can be knocked out, especially the kidneys. So we must keep the kidneys adequately perfused. So there are different types of formula used to calculate the amount of fluid the patient needs. So the common one we use is Parkland's formula, of course, with a constant 4 mils multiplied by the patient's weight. That's why during your assessment, you did your weight, weigh the patient for fluid calculation. So you multiply that 4 mil times the amount of weight. So 4 mil, you're going to infuse each kilogram with 4 mils, then multiply by the actual weight of the patient and the total bent surface area. You would have determined the total bent surface area by this time. The amount of fluid that you get, the total volume, you would divide it as follows. So you give the first half of the total volume of fluid in the first 8 hours, the remaining 16 hours. Then the remaining half, you give it in the next 16 hours divided into 2 doses. So what remains after you remove the half, we divide it into 2 equal parts and give it 8 hours apart. So that will give us 24 hours, right? So we have another formula, Evans formula, that can be used as well, but Parkland's formula is quite effective, right? So this talking about urine output. So normal urine output, you're saying is about 1.5 mils per kg in an hour. So 1.5 times the weight of the patient, that's the amount of urine normally that the kidney filters. Oliguria sets in. This is what we call decreased urine output. When we see that the person is producing about less than 500 mils in a day, anuria, which is no or minimal urine output, or actually complete cessation of urine output, is set at less than 100 mils in a day. That's serious, meaning the function of the kidney is affected or the kidneys are knocked out and they can't perform their functions. When it comes to drug therapy or drug management of pharmacology, which type of drugs are you going to administer this patient? Most importantly, is analgesia and antibiotic prophylaxis. Analgesia, you're managing pain. Prophylaxis, you are trying to prevent infection. So this could be topical or orally administered antibiotics, mainly broad spectrum antibiotics covering both gram negative and gram positive, depending on the depth of burns. The pain can be severe, or patient may have painless, burns. So where there is severe pain, of course, after assessing the pain levels, usually we give opioid analgesia. Then we go back to non-opioid analgesia. In addition to that, tetanus toxoids may be used also to prevent infection by Clostridium tetani. Remember, the skin is broken or will be exposed at some particular point in time, and this particular microorganism, the Clostridium species, are anaerobic and they love deeper tissue, so they can actually cause infection and lead to various complications such as wet gangrene, which is another serious issue that may cause death to this particular patient, especially young children. So air irrigation and debridement of the wound is important. Of course, dressing followed by that. So different types of dressing can be used, open, closed, or moist dressing. Nursing care. When it comes to nursing care of this patient, most importantly, we want to prevent infection and ensure that the patient is well hydrated. In addition to that, we'll continue to monitor, especially vital signs, input and output where fluids are concerned, then ensure the patient receives adequate nutrition, environment is clean, and so on. So when it comes to environment, we have to make sure that environment is clean, noisy free, enough lighting, and adequate equipment available to respond to any emergencies. So provide Macintosh or draw sheet to prevent soiling, bed cradle, of course, to lift off the linen. Oxygen may be administered, okay, depending on the type of burns. Now, when it comes to observation, we are focusing on vitals first. Vitals are very important because this will serve as a baseline information that we use to compare our subsequent intervention. They can also help us to detect onset of various complications such as hypovolemic shock, infection, anemia, and what have you. So monitor input and output, especially for overload, right? So in cases of overload, patients may develop generalized edema or pulmonary edema, right? Then you have overinfused fluids. Pain is important, especially if it's there. We manage pain by use of analgesia. In addition to that, make sure the position of the patient is away from the injury site. Depending on the pain levels after assessment, we start with strong analgesia, mainly opioids. Those are used for severe pain. Then mild, moderate pain, you can use non-steroidal anti-inflammatory drugs or any other non-narcotic analgesia. Cyclooxygenase enzyme inhibitors, ibuprofen, aspirin, and other types of analgesia. In rare cases, Valium or ketamine, these are anesthetic drugs that can be used to at least provide some relief. So patient, mostly they will be drowsy and sleepy and thereby blocking pain. Stimuli. What is important when it comes to wound care is maintenance of aseptic techniques. We don't want to infect the wounds. Of course, clean the wounds with appropriate antiseptic solutions, povidone, iodine, Savlon. and then dressing the wounds then after. That applies for infection control. Now, infection control starts with the environment where the patient in, hand washing, especially of the people handling and cleaning the wound. Then the patient, him or herself, must be educated and advised to first of all maintain good hygiene and also wash their hands and avoid touching the wound to prevent infection. Position, I think we talked about that. Exercise is important to prevent contractures, also prevents, things like constipation and so on. Emotional support is important, when someone is bent, there's disfigurement that accompanies that. So, counseling may be provided. Reassure the patient. What is important is, of course, do not give false hope. I think this spelling is not correct. Supposed to be FALSE. I beg your pardon for that. Nutrition, of course, what is important is replacement of lost fluids and electrolytes after calculation with Parkland's formula. Ensure that the diet promotes wound healing. So high protein diet, high energy diet, and then the body will do the rest. Health education is infection prevention, signs of infection, and prevention of, accidents within the environment. Okay, there are various equipment that can cause injury. There are things that are electrical. Some of them are using highly flammable gases, especially those where you're using cylinders for gas, oxygen administration. Burns can lead into another burn. So educate the patient on various ways of preventing that. Then rehabilitation may follow much, much later on. Complications, of course, wounds. Most of the complications, especially when it comes to immediate complications, shock, neurogenic shock, or patient may have hypovolemic shock. Patient may have hypothermia because the skin is broken, which is an important organ of thermoregulation, dehydration, renal failure. Because of diminished cardiac output, diminished flow of blood to the kidneys, causing insult to the kidney function unit called nephrons. That can cause renal failure. Cardiac failure, of course, with the significant drop in blood volume. Infection, very common. Skin is exposed. Various microorganisms found sometimes in our hospital setup, those sometimes in the community, and wounds become infected. Toxemia, sepsemia comes in, patient may die. Later on, amputation. So depending on the extent of damage, patient may have an amputated limb, either upper or lower limb. Anemia. Sepsemia and toxemia, of course, those who go hand in hand. Liver damage, infection, especially gangrene, gas gangrene, seen by Clostridium or caused by Clostridium tetani. Contractures. I mentioned eschar formation on joints, so that may limit mobility in that joint and cause contractures. Deformities and actually keloid formation. This is oversecretion of connective tissue in the process of wound healing. So you see masses of overproduced, connective tissue in the areas of the wound. And that may cause some cosmetic disturbances. Otherwise, this is where we end for today's discussion.